I hope you all had enjoyable afternoon workshops, and well done for staying around to the end of the day. My name's Marika, and I'm a paediatric infectious disease trainee in Liverpool, but today I'm in Malawi. And I'm delighted to present to you our ICHG Annual Research Award winner, who in 2021 was Dr. Liganga. So Dr. Liganga is a young Tanzanian medical doctor. He holds a degree in medicine from the Catholic University of Health and Allied Sciences in Mwanza, Tanzania. He did his internship and worked for 1 year in the ENT department of St. Francis Referral Hospital, Tanzania. He's currently a second-year student taking a Master of Medicine in otolaryngology at Kilimanjaro Christian Medical University College in Moshi, Tanzania. Dr. Thadei is interested in research, paediatric ENT, rhinology and invasive skull surgery, and his goal is to help children with ENT conditions in developing countries to attain the best possible health state. So we are both going to go in the backgrounds, and we'll play Dr. Linguanga's pre-recorded talk, and then he will join us for questions at the end, okay?
College in Moshi, Tanzania. It is really an honor to be presenting in this conference, and I'll be sharing with you the pediatric airway cause outcome in Moshi. So before I begin, I would like to thank ICHG for funding our project and for making this presentation possible. Here is the outline of my presentation. So a little bit of introduction. Kilimanjaro Christian Medical Center, KSMC, is a referral hospital in northern Tanzania, serving 4 regions in the northern zone, and these include Kilimanjaro, Arusha, Tanga, and Manyara. Being a referral hospital, a zonal tertiary hospital, it works with the Kilimanjaro Christian Medical University College, acting as a center for research and training of various medical personnel in the fields of laboratory, medicine, nursing, pharmacy, and clinical research, to mention a few, at all levels from undergraduate to postgraduate levels. So in May 2022, we conducted an airway course at the KSMC ENT department. This course involved ENT residents from other departments in the hospital, pediatricians, medical students, and nurse anesthetists. This 3-day airway course was given in form of lectures and practices that involved simulation of airway emergencies. We had 2 ways of measuring the outcomes of the course. One was the confidence score improvements, and the other one was to assess the postoperative outcomes of pediatric patients that underwent surgery in our department. So regarding the confidence score improvements, each participant was given a form to fill prior to the course and after the course. These forms were rated with a Likert score of 0 to 7, 0 being not confident at all, and 7 being totally confident. The mean scores were calculated prior to the course and after the course, and the mean difference was established to assess on how the course had boosted their confidence in various areas as seen in this table. So the results. Overall, medical students showed the highest score improvements. They showed the best improvements in all areas, as you can see in the 4th row. And this is because of all the trainees, medical students were the least knowledgeable, they were the least experienced, and most of them were new into the clinical area, so they had no experience in managing these airway emergencies. So the course had boosted their confidence by a really great amount. The nurse anesthetists, as you can see in the 2nd row, showed the least improvements in many areas, and this can be explained by the fact that they were already knowledgeable and experienced in dealing with these issues even prior to the course. So their true scores before the course were already high, and the difference after the course was not that much. So in all areas they showed the least improvement, and this is because they were already confident, they were already knowledgeable, and they had a higher scores even before the course. For pediatricians, if we check the third row, they showed the greatest improvement in managing seriously ill children, a change of score by 5. Now, this is something that we are really proud of, because it tells us that the course has significantly boosted their confidence in managing seriously ill children. I know I am speaking to a number of pediatricians here who are really experts in managing seriously ill children. But in our case, we are talking of seriously ill children with airway emergencies. And the fact that the course has boosted their confidence significantly in managing these cases is something that we are proud of. They showed least improvements in managing post-tonsillectomy bleeding. If you check the third row, the third column on post-tonsillectomy bleeding, there was actually no improvement at all. This does not come as a surprise, because post-tonsillectomy bleeding is directly an ENT issue, because the pediatricians do not directly deal with surgery. So it is directly an ENT issue. It's a job of an otorhinolaryngologist anyway. For ENT residents, there was moderate improvement in all the areas. They had the highest score improvement in cricothyrotomy. The first row, the last column, 3.9. So this scores boosted their confidence more in that area. And this is more likely because cricothyrotomy is not performed as regularly as tracheostomy. So this scores boosted their confidence. And they scored lists in they had a list score improvement in the blocked pediatrics tracheostomy. This can also be explained by the fact that they were already confident in that area. So when you check out the true scores, you'll find out that they had a higher score prior to the course, and their score did not change significantly after the course because they were already experienced in that area. So overall, these scores give us a picture and a guide or direction for further courses on areas where we should focus on in the future for other courses. So this was one of the ways of measuring the outcomes of the course. The other way of assessing the outcomes of the course was a clinical method, and that was to assess the postoperative outcomes and complications among all pediatric patients who underwent various surgeries at KSMC and T departments. So we did a 3-month study which enrolled 425 patients, among which 21 complications occurred, and this is equivalent to 5%. Of all complications, infection was predominant, accounting for 57%. And these included surgical site infection, pneumonia, and septicemia. Post-tonsillectomy bleeding accounted for 38% of all complications, and laryngoedema 5%. We had 16 readmissions, equivalent to 3.76%, and 2.1% of all patients had to undergo reoperations, and most of these were due to post-tonsillectomy bleeding, which required examination under anesthesia and cauterization to achieve hemostasis. We had zero mortality in our study, and this is something that we are proud of, and it actually tells us that we are doing better than some of the developing and even some of the developed countries. This now brings me to the second part of my presentation, introducing the pediatric ENT surgical outcome study in Moshi. This is going to be a one-year evaluation of patient care and perioperative clinical outcomes for pediatric patients undergoing surgery at KSMC ENT department. So this is to build upon what we have started, to build upon the pilot study that I have just described. Access to safe surgical care is every patient's right. Now, a number of studies that have been done show a gap in terms of access to and quality of surgical care between low and middle income countries and high income countries. The South African Pediatric Surgical Outcome Study, which was a 14-day prospective observational cohort of all pediatric surgical patients, showed that the incidence of postoperative complications was actually double the rate in high-income countries as compared to the low and middle-income countries. And these poor surgical outcomes were attributed to deficits in human and material. I think we all know the ASOS, the African Surgical Outcome Study, which enrolled more than 11,000 patients. This study was done in adults, and the postoperative complications were 18.2% among all patients. In this study, the mortality was 2.1%, of which 94% of all mortalities happened after the day of surgery. Infection was the predominant complication, accounting for 10.2% with a 9.7% mortality. The South African Pediatric Surgical Outcome Study, which was done among the pediatric population, enrolling about 2,000 patients. In this study, the postoperative complications were 9.7%, predominantly infective. The mortality was 1.1%, and the mortality was related to risk factors such as the ASA, physical status, urgency of surgery, and an infective indication for surgery. Many ENT operations deal directly with the airway, and these shared cases now are a noteworthy subgroup of surgical cases in which perioperative complications could have significant morbidity and mortality. So it's important to assess them as a special group of operations. In a study that was done during the COVID-19 pandemic at Evelina Children's Hospital, 3 complications were recorded among 56 patients who underwent surgery. Now, at KSMC ENT, we perform anecdotally more than 2,400 operations in a year, of which more than 80% are children below 16 years. Adenotonsillectomy is accounting for more than 90%. In our department, the magnitude of postoperative complications is still not well known despite the large number of surgeries performed daily, and hence the necessity for this study. So the objectives of this study are the primary objective is to determine the incidence of in-hospital and community postoperative complications up to 14 days post-surgery in all pediatric patients undergoing surgery at our department. The secondary objectives are to determine the in-hospital perioperative mortality rate up to 14 days post-surgery, to determine the incidence of intraoperative severe critical incidence, and also to determine the association between preoperative and intraoperative factors to postoperative complications and death. So this a summary of our study. It's going to be a one-year prospective observational study conducted at KSMC and T department, and we are expecting to enroll 2,000 patients. The study will include all consecutive pediatric patients aged less than 16 years undergoing various surgeries at KSMC and T department. The pilot, as described, has been done from August to November 2022, and the study is proposed to start at January 2023 and end on December 2023. So at this point, I would like to request the assistance of this audience and all the pediatric stakeholders around, just if they know of any appropriate funding streams that would make this project a reality. So I would like to thank Dr. Peter Shija, who is the head of ENT department at KSMC, Dr. Kenneth Mlai, who is the ENT postgraduate coordinator at the Kilimanjaro Christian Medical University College, and Dr. Tom Hampton. Lastly, I would like to thank ICHG for funding our project and making this presentation possible, and thank all of you for your attention. Thank you for listening.
Dr. Liganga, for that really great presentation. Well, I think we have time for just one quick question. I think one of the things that we most were impressed with in your application was the multidisciplinary, multi-speciality nature of your training intervention. I don't know if you wanted to comment on how your course, if you can comment on how your course was able to enhance multidisciplinary learning. I think Dr. Liganga has having a difficult connection at the moment, but we'll thank him so much for taking the time to come today and for pre-recording his talk, and we're really excited about the future work which will come out from this. Thank you. Okay, so I think we'll go on to our next session then.
Hi, everyone. Hello again. This is Iva, one of the colleagues of ICHG Winter Meeting. Thank you so much for staying too long until the last session to basically be a part of this great day. Hope you have been enjoying the session so far. So we were normally planning to have Mr. Darien Castro, who is a young speaker and young climate activist representing children and youth constituency to United Nations Framework Convention on Climate Change. But unfortunately, due to some technical issues, we couldn't have him here. So we have got a pre-recorded talk from Mr. Darien Castro, and hopefully we will just we will be sharing this with you. So allow me to introduce him first to you, and then we will be hopefully be able to just share the video. Mr. Darien Castro is a researcher and biologist. He has collaborated with indigenous leaders as a volunteer and then as a partner in human rights, and then in territorial defense campaigns as Amazon and Andean communities in front of the Congress and manifestations. Mr. Darien has also worked for International Agenda and is part of worldwide climate action and scientific initiatives and on studies for Worcester and UVI Press 4 articles. So we are now gonna share the pre-recorded talk with you. You are still free to put your questions on the chat at the end of session. We will be able to just send the question to Mr. Darien. Just feel free to put your questions again on the chat box at the end.
Hello, everybody, and hello to all the Royal College members in this ICHG meeting. Today, we will talk about how is the conditions of the youth with the climate change. That relation that unfortunately we just lost in our minds, but it's so necessary to understandable, especially in a healthcare system, and that relation between the integral health and the climate change of our next generations. However, I would like to share and mention some of the visions that we have, like youth representatives around the different events and conferences. In my case, conferences like the COP26 and COP27. What's the deal with these events? The COP26 was developed in Glasgow, UK, in November 2021, like a postponed version of the 2020 Conference of Parties because of the pandemic situation that we suffered during that year. During that year, we get some achievements respect to the reduction and monitoring of the carbon emissions and GHG emissions too. However, the worst thing that we couldn't get was the reduction and eradication of the subsidies in oil and fossil fuels. Yeah, it's a challenge that we have. But what really happening right now with the COP27? So well, right now our new challenge, like was a great challenge in the past, is the loss and damage claim. It's so complicated to understand how the world leaders, especially in the global north, try to understand the position of the global south countries and vulnerable groups when they don't have the responsibility to give us a better future, but especially to mitigate the damages and the collapsing of the system in economical and in a social level because of the climate crisis. These positions, so that's the reason because we start to ask ourselves, what's the position of the youth groups and organizations to face the climate change, and especially how we can expand our actions and what's our goals like a young generations to fight against this mean. So well, we will talk about some of the activities that we do. As part of Yongo, for example, we have uplift different conferences, but especially in different negotiations tables and round tables. But the real thing and the real problem is that these kind of activities and this kind of spaces that we have are not applied in the real progress of the agreements, or especially in the ending of these conferences. So we are so worried about the participation of these groups in the policy making and taking decisions in the priority and surviving against this event like the climate change. Some of the events that we can see or representatives can participate, it's side events that are different topics and different areas like health, social level, indigenous rights, and even sustainability development, adaptation, and mitigation. In all of these spaces, we can see the abilities and skills of our young generations and how they can provide of new ideas and have an innovation capacity for us. We can see another great skills like, for example, the speech making abilities in high level segments where we can see our representatives of these minorities, but especially of the young generations, talk with a strong voice about the problems and the consequences in a short and a long term of this reality. But what really happening post COP27 and post conferences of Paris, all these versions that we have, and maybe we will have another in the future. So well, we have a great problem with the take and making decisions of our leaders because they start to ignore our real meetings in these kind of agreements. It's a reality, yes it is. And we can talk about two topics that we think it's a real priority to understand what really happened, to understand the real effects in our young generations and even in general, overall, in all the people, in all the population, like adults too. It's necessary to understand two areas of the integral health: mental health and physical health. In the mental health, we can see that exists a real tending to the crisis and chaos because of the lack of resources that can translate it in different disorders and patterns that can be stimulated in a macro population approach or in an individual level. We can see, for example, disorders of psychotic disorders and the increasing of new mechanisms of defense in the mental health, like for example, psychosis. Exists another disorders respect to eco-anxiety and the other patterns that can get involved, like depressed, stress. All of these, all of these symptoms can be a signal of the trending of our populations in terms of a society that is facing not only the climate change, even another consequences of the climate change, like the increasing of violence in some territories where exists a lack of natural resources or basic services like the water or even the minerals and the territories. That kind of things start to promote a new collapsing in a mental area around the populations in the world, and especially in the minorities and vulnerable groups. We can talk about the ethnic groups. We can talk about the minorities like in the women, more violence to the gender, and especially more violence in general with the association with criminal groups. And that trending is a result of the lack of opportunities or lack of resources and the lack of guarantee of food security in some areas because of natural disasters that promote antisocial activities that can produce resources or produce a success or fake success in the society. Now we can talk more about the physical health. And it's so obvious and evident that exists a great relation between epidemiological patterns and the climate change and the degradation and destruction of ecosystems, like natural barriers that defend us against these vectors or possible transmissions of viral or bacterial diseases that we believe that were eradicated in the past. But right now we can see new spreads and new outbreaks around the world. The monkeypox and the COVID-19 are some of these samples of zoonotic diseases that were transmitted and spread for vectors that amplified their distribution, their natural distribution, uh, up to the limits of their ecosystems because of obviously the expansion of the urban spaces and the destruction of rainforests and other biomes that are so important to keep the stability in these habitats. So what's the conclusion with all of this? It's so complicated to understand that all of these factors related with, for example, the destruction of ecosystems and the zoonotic diseases and the lack of food security and natural resources loss are related with topics that are so human, like the psychological disorders. Yeah, who knows? Many people don't understand this relation, but we are here to explain that. We can see, for example, the degradation and the increasing of temperatures and solar radiation are not only a consequence of the climate change because exists external stimulation of other activities, like for example, not only with related with fossil fuels, even with nuclear weapons. We know data about that we can see in these graphics. So what's the thing that we need to do right now? Understand that the future is not only for the people that making decisions in the present. The future is for the people that really want and really live that future in in maybe one day or 1 year or several years. The selfish thought and the construction of a fake paradigm against the needs and the well-being of all generations start to collapsing. All about the humanity, the essence of humanity in a mental health approach, and the collapsing of a system that that obtain the resources in an infinite level with a finite level. Thank you for coming in this session, and I'm so happy to be in here. Thank you.
Thank you everyone for listening to this session as well. If you have any questions for Mr. Darien, you can just directly send them to us and we will be happy to just direct those questions to him. And apologize for the networking issue again. So we are just now going to move on to the closing bits, if that's okay for everyone. I'm just going to invite all the committee members to the sit-in.
Great. So thank you so much, everyone. It's for staying with us. It's been a long day. We're just waiting for one more person. So as I'd said previously, my name is Marika. I'm the Deputy Convener of the International Child Health Group. This is the 4th winter meeting I've been part of organising. And I'm sure you can all appreciate that it's been a fantastic meeting today. I'm so proud of our team. This has been a really new area for ICHG to work in, but we felt that this was probably the most pressing issue facing children globally, so that it was something that ICHG needed to tackle. So thank you to Vasina, Sri Rambad, Maria Marcolin, Helen Dale, and then our final committee member who was unfortunately on call today, Laura Wilkins. We are all, I think all of us actually are all trainee paediatricians, so we're all doing this in the early mornings, weekends, free times. So please congratulate them. I think they've done an amazing job. We'd also, on behalf of ICHG, I'd also like to say a huge thank you to all our speakers. There's been a huge number, particularly those that have given up time from clinical jobs or from the COP27 meeting, where a lot of people have been very busy over the last couple of days. And to all our workshop facilitators from around the world. One of the beauty of an online virtual meeting is that we can have both speakers and participants from around the world. And I think we've seen the benefit of that in today's talk today. Thank you so much to our committee. They've done a fantastic job. I'm just going to talk to you a little bit about ICHG before I then hand back to Sri and Eva to sum up the day. Can you see my slides? Oh. Yeah, okay. So for those that don't know you, the International Child Health Group is a special interest group of the Royal College of Paediatrics and Child Health. We aim to support healthcare professionals interested or working in global child health. We are primarily individuals, but are connected through our network globally. And we offer free membership to residents of low and middle income country. We work primarily through advocacy, education and research. In ICHG, we value justice, equity and diversity as we partner with a global network of professionals to promote a child-focused approach to global health issues. Recognising we can learn much from each other, we are inclusive and respectful, whilst encouraging good practice and research. The group strives to inspire and equip students and health professionals to engage with current issues in global child health. So if you're not a member, please do consider joining. We offer free student membership and free membership, I've already said, to residents of low and middle income country. And we have a growing and increasingly diverse membership group. We have 2 meetings of a year, this meeting and our RCPCH meeting in the spring. We run research, intercalated, elective and advocacy awards, which please do apply. We have a monthly bulletin and social media. We have 3 working groups, which all our members are very welcome to join, and we actively encourage participants to be part of, which I'll talk about later. And previous work that we've done has included advocating for inclusion in global child health in the RCPCH curriculum, training courses, and we have a long-standing collaboration with CHIFA, which is Child Health Information for All. So our education and training working group is open to anyone to be a member of who's a part of ICHG. We meet once a month. It's quite new, but we've already got 24 members, ranging from students to extremely experienced global academics. And we're looking at webinars, coming up in the new year, and career-focused events as well. As also as part of our educational and training group, we have a mentorship program, which again is open to anyone around the world. We have an absolutely incredible range of mentors and mentees from around the world, and this will be launching in early 2023, so please do keep an eye out to sign up. Our advocacy group is one of our absolute something we're extremely proud of, and again it's all run voluntarily by our members. The work streams are divided into proactive advocacy, migration, displacement and child health, and reactive advocacy, and you can see some of the work streams and the leads listed here. The aim is that this is affiliated with RCPCH, so we are able to amplify our voices using RCPH when possible, but that we are independent of them. We focus on defence and promotion of child and human rights, and it's a space for ideas on how to effectively advocate for child health globally, and really is about bringing like-minded child health professionals together. Our research group is also fairly new. We also meet once a month. We manage our research prize, and we're really focused on how we open up research to child health professionals around the world, knowing that actually opportunities aren't always equal, and also that globally not enough child health professionals get actively involved in research. We've set up a network to provide advice and connections. We've run numerous career seminars and projects looking at equitable authorship and the paediatric global surgical workforce. If you haven't already listened to this is our fantastic podcast by our convener, Professor Delanda Fakuma, interviewing a really diverse and exciting range of global health professionals. I certainly find them incredibly inspiring. So we really do hope that you will consider, if you're not a member, please join. And if you are already a member, please consider more actively becoming involved. We really are a growing organisation, and we're a great space to link up with like-minded individuals. And there's huge opportunities for, if you have something that you are interested in, that actually ICHG can help you as the vehicle to develop it. So thank you very much. So I'm just going to hand over to Irva and Shri. And thank you so much, everyone, for attending today. We've been absolutely fantastic participation, wonderful comments, a huge amount of learning from everyone who's here. Thank you.
Thank you. Thank you. And I'd like to say a big thank you to Marika, because I feel like she's been the guiding star for this whole project. She's brought the experience that we probably would have definitely failed at the first hurdle without. So yeah, thanks, Marika. It's been absolutely essential to have you around. Fine. So I just want to do a quick summary of everything we've learned today. So we'll start from the start. So the world's poorest children and minoritized groups experience the greatest harms of climate change, and we need to stand beside children globally as child health advocates. Governments and companies continue to prioritize fossil fuels over people's health, but we need to ensure that the government understands that women and children need to be at the center of climate change and the sustainable development groups. In terms of the group workshops, we've learned that we need to leverage knowledge from communities and educators and work collaboratively to highlight how children are at the sharp end of climate change. There is a free copy, there's an educator's guide to climate and health justice, which is available via Race and Health, so you can reach out to them for a copy. Mental health and climate change is a very important issue. So an example of that is that there's an extra 22,000 suicides in Mexico and USA due to higher temperatures as a result of climate change, which is an unacceptable outcome. But we must do our part as child health professionals to try and first pass out the effect of climate health on children's mental health, and then try and change it both at a local and at a policy level. We also need to work within the movement ecosystems to be advocates, and this involves sort of challenging institutions, personal empowerment through education, but also building alternatives to the system that we have now, either that be through education or through the advocacy via the ability we have now. Moving on to air pollution, we realize that actually air pollution is equivalent to lead poisoning. So it's unacceptable that we still tolerate the amount of damage it causes to our children. It's, again, a point of equity because children produce the least air pollution but are most susceptible to it. And air pollution damages lung growth at a critical stage in children's lives, which is a critical indicator of all-cause mortality. And because of the hard truths that Prof. Sinha and Prof. Masekela told us, we need to speak more frankly both to policymakers and to local community policy action makers. So children will literally die because of air pollution, and we can't rest on our laurels about this, and we can't be soft-spoken about this. And we need to give power to individuals and communities and inform people about the health harms of air pollution and action that they can take to reduce their exposure. Also, vaping is terrible. It's just as bad as smoking, and I don't know why we people do it still. Climate, so cities, children, and climate. So this was a really powerful look at how we involve children in determining the direction of our advocacy work, and actually it put the onus on them to tell us how to do things, and instead of just asking for their opinion and actioning it, they would then action it, which is really important. And I think that checking them out would be definitely a really good idea. And then we moved on to the migration plenary, and we talked about our children are trapped in higher risk settings, and we know that children are more vulnerable to the effects of climate change, so we need a sustainable rather than a reactive solution, and that migration can affect all impacts of health, and the long-term effects are not fully known. An important point to note is that there is a handbook for refugee health for healthcare professionals and humanitarians providing care to forced migrants, which we can provide links to in the resource pack. And then finally, just think about child rights, tax, revenue, justice. So for every additional year of schooling that girls receive, the country's resilience to climate change improves because educating girls has an impact beyond the individual. The impact of tax cuts and revenues do not affect all countries equally, and that aid may be a sticking plaster, whereas tax justice is more of a sustainable and equitable solution. And there have been recent landmark decisions which allow for advocacy across borders so that we can provide justice for children in different countries as well. And then we had a great talk from Dr. Liganga about the PESOM study. And if anybody has any great ideas of how to provide funding for this great and very important investigation at the Kilimanjaro Christian Mission Hospital, then please get in touch with us and we'll try and get you in touch with Dr. Liganga. And then finally, we heard from Mr. Castro, who is a youth advocate, and he spoke about how his experience as a biologist has really impacted his knowledge of how climate change is affecting indigenous communities within the South American continent. So thank you very much. I hope that was not too bad of a run through. That's what I've learned so far. And we will get out a resource pack to you guys alongside a post-survey questionnaire, which would be grateful for if you could complete that. We would also be very grateful if you could give us a few weeks to get your participation certificates for CPD and things like that ready, so we can send them out to you in time. And then I'll pass over to Hervé to finish off, if that's all right.
Thank you, Shiri. I don't know what to say after this very informative, very deep summary. But I'm gonna say we'll just remain very small. What you just by the things you said, but I will just try my my best. So I would like to just thank all of the organizing committee members. Sherry, first, it was such an honor to just share this leading position with you. And then Marika for the guidance along the way. And then Helen, Maria, and Laura, it was such a privilege to work with you. So I think we really had a very important and informative day with all the amazing speakers, and all of them highlighted very dramatic evidences that we can't ignore as child health professionals. So, I once again realized that climate change is one of the biggest threats to children's well-being, and has a very much deeper impact on their health than we think and we realized so far. And I hope that everyone felt the same way as me, and bringing at least a couple of important messages with them when they leave today. And I just wanted to highlight again before we go that as Professor Costello said, we shouldn't underestimate the individual's response and contribution in climate action. And there's actually so much impact of what we are individually doing on the collective response. As he highlighted again, please just continue talking about climate change in every format and every platform. Use electric hybrid cars, walk, cycle more, reduce, reuse and recycle, and switch to largely plant-based diet if you can, and switch to renewable energy. And these are the things, I think, looking very small, but actually very important points that we can just start today. And because we can also encourage the people around us to just do the same. And when we start, I believe that once we start adopting these changes, it will be much easier to be a part of a collaborative response for each of us. Basically for today, it's also often highlighted today that children are usually ignored by government, policymakers, and in the research papers. We should definitely be aware of this fact as a child health professionals, and we need to focus more on amplifying children's voices. As Ilana said in her presentation in Migration Plenary, children are trapped in high-risk climate settings, and the solutions offered are reactive rather than being sustainable. And I think in regards to that, we have so much responsibility, and especially to the vulnerable groups of children, as they may need different ways of engagement and care in the response. Once again, thank you so much for joining us today. Hope you learned a lot, enjoyed the session, and will continue engaging in the ICHG. And I will hand over to other members of the ICHG Winter Meeting Organizing Committee.
I think that's it. I think we're done. Yeah.
Thank you.
I think it's the end of the day. Thanks, everyone.
Thank you, everyone.
Thank you.
Bye.
Yeah, stay in touch. We will get everything out to you that we promised in time, and please join ICHG. It's full of
yeah, please.
Yeah,
Full of people like us.
Yeah, they need. Thank you very much.
Bye.
Thank you.